इमरजेंसी है ना, फ़ोन भी आएगा तो फिर हम थोड़ा वॉच करके हो जाए ना. Good morning. Today we will discuss regarding fetal growth restriction. So, fetal growth can be normal, can be abnormal. Abnormality can be in two ways. One is excessive growth, one is less growth. So, the less growth or inadequate growth, that is also called as fetal growth restriction. Previously, it was told that the term of intrauterine growth retardation IUGR was used for this, but the new term is fetal growth restriction. So, retardation is term is a little different, that is why that growth retardation part is not there. It is a intrauterine fetal growth restriction, not retardation. So, before going into the growth restriction part, I will just tell you regarding something regarding the fetal growth. What are the patterns of, what are the phases of fetal growth? So, you must be knowing the two terms. One is hyperplasia and hypertrophy. So, hyperplasia means whenever the number of certain things or cells increases, and hypertrophy means if something is increasing in size. So, if cell is increasing in size, then that is hypertrophy, and if it is increasing in number, then it is hyperplasia. So, what happens in first 16 weeks of pregnancy? So, the number of cell increases, so hyperplasia are there. Then from 16 weeks onward up to 32 weeks, both hyperplasia and hypertrophy will be there, and beyond 32 weeks, the hypertrophy is mainly seen. That means at late part of the gestation, the cell number will not increase, only the cell size will increase. All the cells will increase in its size. So, due to this, this one is due to the mostly due to fetal fat and glycogen deposition. So, fat and glycogen deposition occurs, weight of the fetus increases, and fetal cell increase in the size. So, these are the pattern in which fetal growth usually occurs. So, that is why more the first part of the pregnancy, if there is insult or if there is any problem, the number of cell will decrease and fetal growth restriction will be more pronounced. So, then this one is a slide showing how the fetal growth rate. So, how the fetal growth occurs across the gestational age or across the time period in which fetus remains inside the uterus. So, here you can see, so at 10 weeks of or 11 weeks of pregnancy, the fetal growth rapidly starts and steeply it increases till it reaches around 35-36 weeks of pregnancy. So, this is for Asian, this brown color is for Asian, and after 36-37 weeks it gradually decreases. So, this is a pattern in which fetal growth occurs, steep increase till 36-37 weeks or 35 weeks, then gradually decreases. So, the rate decreases, not the weight decreases. Weight will remain static or weight will remain little higher, but the rate decreases. So, this is the growth rate. Then coming proper to the fetal growth restriction. So, what is the definition of it? So, fetal growth restriction means any fetal weight which is less than 10th percentile for the gestational age. Suppose for a gestational age of 32 weeks, so the weight may be 1750, and if it is less than 90th percentile of that 1750, then it is fetal growth restriction. Or if abdominal circumference, AC means abdominal circumference. So, by ultrasonography we measure many parameters of the fetus. So, mainly 4 parameters are measured. One is biparietal diameter from here to here, another one is head circumference, third one is abdominal circumference at the level of the liver, then fourth one is the femur length. 4 parameters we usually check for the assessment of the fetal growth by ultrasonography. And after measuring all the 4 parameters, a formula is there, that is called as Hadlock formula or Shepard formula. So, this formula automatically machines calculates and it gives the fetal weight, and that fetal weight, if it is less than 10th percentile for that gestational age, at any gestational age in the pregnancy, so that is fetal growth restriction. Similarly, if the abdominal circumference is also less than 10th percentile, then also it is fetal growth restriction. So, as you know, the soft tissue of the body, that is very much sensitive to the growth pattern. So, that is why abdominal circumference is the only parameter which we are measuring, which is mostly soft tissue related, that means liver. So, liver size usually increases or decreases depending upon the fetal nutrition or fetal blood supply. So, whenever there is a restriction or blood supply or restriction or any disease of the fetus, there may be abnormality in the size of the liver. So, the abdominal circumference that decreases or increases accordingly. So, abdominal circumference is a very sensitive indicator, and effective fetal weight is a function of abdominal circumference, head circumference, then femur length and other parameters also. That is why it is not as much sensitive as the abdominal circumference. Yes. So, these two things has to be taken care while diagnosing the fetal growth restriction. So, then again, what is severe fetal growth restriction? Severe is when there is the percentile is less than 3 percentile. So, 3 percentile to 10 percentile, it is severe. Whenever AC or effective fetal weight is between 3 percentile or 10 percentile, it is less than 3 percentile, then it is severe. So, less than 10, that means 3 to 10 is fetal growth restriction, less than 3 it is severe fetal growth restriction. And if there is any abnormality in the Doppler, Doppler you must be knowing, Doppler is a physical physics principles of the physics, in which whenever any ray or any wave is incident on any moving object, it changes its phase. Suppose a vehicle is running like this, a wave is colliding with this. So, after colliding and getting reflected, the vehicle moves a little. So, this difference in the distance it moves, the phase of the wave changes, the phase of the incident wave and the phase of the receiving wave, that changes. So, that is the same principle here you are using for the Doppler in the fetus. So, the blood moves and the ultrasound wave hits the blood cells and again returns back. So, the difference between the incident wave and the returning wave, the phase difference, that is represented as Doppler shift, and this Doppler will give you indication how the blood is moving and what is the velocity of blood moving inside the fetal blood vessels. So, if the Doppler indicates that there is restriction of blood flow in the fetal umbilical artery, then it is also called as severe fetal growth restriction. So, what are the abnormality I will tell you, I will show the diagram also. So, if severe, if it is less than 3 percentile or if it is abnormality in the fetal Doppler, got it. So, then two terms are there, one is FGR, fetal growth restriction, and another is SGA, small for gestational age. So, you should not be confused with these two terms, that is why I have put it here. So, FGR means fetal growth restriction, that is detected by prenatal sonography. By doing sonography, you have to measure the various parameters, as I have already told, and by measuring it, if you are estimating some weight or AC. So, if that weight or AC is less than 90 percentile, then that is FGR. So, it is primarily detection of fetal growth abnormality during prenatal period by using sonography. But SGA is a postnatal description or postnatal designation. So, after delivery you are measuring the weight of the baby, and if at that gestational age baby weight is less than 90 percentile, then it is SGA. So, the very easy difference between the two, one is after delivery measuring physically, another one is measuring during the pregnancy by ultrasonography. So, FGR is always not equal to SGA, because there are somewhere inherent errors in the sonography measurement will be there. So, sonography measurement is not 100% accurate. There may be 10% or 20% plus and minus from this side or that side. So, that is why SGA is not always same as FGR after delivery. Got it? Then SGA is not always pathological also. Not always pathological also, because the mother of the baby may be a small height, father may be of small height. So, if the both parents are smaller or dwarfer, in that case baby will also be small. So, that is called as constitutionally small. And if there is some in certain races like Chinese people, Japanese people, they are short height. So, in that case if you use the growth chart of the Caucasians, it will be wrong. So, racionic variation and growth parity, weight and height, all these things should be considered before labeling some fetus as SGA or not. So, you must be clear by now what is FGA, FGR and SGA. Then regarding another two description, one is early and late FGR. Early FGR means whenever it is onset less than 32 weeks of gestation. Late FGR means whenever it is more than 32 weeks of gestation. So, 32 weeks is a cutoff. It is taken as cutoff because the etiology of the FGR and the management of FGR before 32 and after 32, that is different. So, before 32 there are certain particular risk factors are there, certain particular causes which causes FGR, but after 32 there are certain different other causes are there. I will tell you in detail. So, how to diagnose the FGR? So, before diagnosing FGR we should know the gestational age correctly. If you do not know the correct gestational age, your calculation will also be wrong. So, knowing the gestational age can be done by two methods. One is by LMP. LMP means last menstrual period, and another by using the sonography. So, last menstrual period we must be knowing the first day of the last menstrual period. From that, how many days has passed or how many weeks has passed till today when you are calculating, that is the gestational period. By sonography, what you have to do? You have to do a sonography in the early gestational age. So, anyhow we are doing ultrasonography whenever pregnancy is diagnosed, and early gestational is the best time for estimation of the gestational age. So, later on when the fetus will increases in size and gestational age, the error in the estimation will be more. So, that is why early gestational age sonography or LMP you have to consider for the determination of the gestational age. So, if LMP is not so sure, then sonography is taken care. If sonography is not done in the early gestational age, then LMP will be taken as a gestational age calculation. Then if you have made the gestational age confirmed, then you have to see by clinical examination. So, a fundal height if it is less than 3 centimeter than expected for the gestational age, then it may be FGR. Other causes are also there. If there is liquor is less, fetal IUD has occurred, then in that case also fundal height will decrease. but if those things are not there, then it can be FGR whenever less than 3 centimeter fundulite is recorded. So, what are the risk factors? So, many risk factors are there, and risk factors can be divided into 3 parts or 3 according to the etiology. One is woman etiology, one is fetus, one is placenta. So, if the cause is inside in the pregnant lady, then it is woman, if it is in the fetus or if it is in the placenta. So, in the pregnant woman, if there is poor gestational weight gain, if the woman is constitutionally small, if nutrition is less, any social deprivation is there and eating disorders are there, then these are the condition in which the lady is responsible for the or the causes are lying in the lady. And in fetus, if fetal malformation is there, that also cause FGR. In the combined woman and fetus, drugs and teratogens, if any drugs and teratogens are given, both that will affect the mother and the fetus, and that's why it is the overlapping in the overlapping category. So, in placenta what happens? Placental abnormalities like subcensurate lobe or circumvallate placenta, many types of placenta, or if there is any chorioangioma, all these things are placental causes of FGR. So, the combines are maternal medical condition like hypertension, those things will be common with the woman and the placenta. Genetic abnormality or multifetal gestation are common with the fetus and the placenta. So, 3 compartments of etiology and 3 are overlapping, and here you can see 3 are overlapping, all the 3 will be there in infection. If infection occurs, all the 3 compartments will be affected. So, now we will discuss regarding the common causes. Common causes one by one I will discuss. One is gestational weight gain. So, if gestational weight gain is less, then FGR can also be there. So, a normal weight, a normal BMI woman should gain weight of up to 9 to 11 kg. So, if the weight gain is less than that, it may be 7, it may be 5 kg. So, in that case there may be chances of FGR, but this is not same for the overweight ladies. If overweight ladies are there, they should gain weight up to 7 kg only. Then some socio-economic factors like smoking, alcohol and substance abuse, these are also implicated for the FGR. Then vascular diseases like preeclampsia, this is a most common cause of FGR in the clinical condition, in the clinical scenario. In our condition, we see if preeclampsia is there is a high likelihood chance that baby will be having FGR. And renal diseases like glomerulonephritis, nephritis, chronic renal disease, those are also causes FGR. Pregestational diabetes, this also causes FGR whenever the diabetes is of prolonged duration. If duration is much more, there will be more vasculopathy and that causes FGR. Chronic hypoxia, that causes decreased blood flow to the fetus also, and that causes asthma, the causes are asthma, chronic cyanotic heart disease and smoking. So, these are the chronic hypoxia condition in which there can be decreased blood flow to the fetus and that can cause FGR. Certain anemias, not all anemia will cause FGR. Certain anemias like sickle cell disease and other inherited anemias that can cause FGR. Sickle cell disease, what it causes? The blood inside the vessels that sickles means it forms the sickle like forms. So, it blocks the small capillaries. So, that is why the blood supply decreases. So, certain anemia will cause FGR. Other causes like antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. So, this is a condition in which there will be hypercoagulability. So, blood coagulation chances increases, and there will be thrombosis inside the placenta. Due to the thrombosis inside placenta, there will be decreased circulation and fetal growth restriction occurs. Placenta cord and uterine abnormality, as I have already told, chronic placental abruption, small amount of bleeding is continuously occurring inside the or behind the placenta. So, that decreases the effective nutrient transfer. Infarction inside the placenta, chorioangioma, velamentous cord insertion. These are the many conditions related to placenta cord and uterine abnormality that causes FGR. Multifetal gestation, it is self-explanatory. If the substrate is same, that substrate is derived from a single mother, and fetuses are 2 or 3, there will be decreased nutrient transfer to a individual fetus. So, that is why multifetal gestation are often FGR. Medications and other substances like antineoplastic drugs or anti-cancer drugs, tobacco, alcohol, lead exposure, these are also causes FGR. Certain infections like maternal and fetal infections, rubella, CMV, TB, syphilis, toxo and malaria. So, malaria is very common in our country. So, in endemic areas of malaria, there can be FGR, and these infections like torch infections, that also can cause FGR, but it is not so common. Congenital malformation can also cause FGR. The most strongly linked is the gastroschisis. Gastroschisis, you must be knowing, it is a malformation in which the abdominal content, the abdominal viscera, the intestine, liver, that may come in through the abdominal wall defect. Usually the defect is the umbilicus. So, the intestines comes out. So, this is the condition in which there will be congenital malformation. There will be more chance of FGR. Congenital cardiac anomalies, mostly cyanotic heart diseases, also cause FGR. Genetic abnormalities like trisomy 21, 18, 13, Turner syndrome, confined placental mosaicism, these are also causes for FGR. So, these are some of the causes of FGR, common causes. So, after knowing the causes, we have to know when to do the testing for genetic causes and when to do the testing for infective causes. So, many causes it is evident, maternal illness it is evident, but certain diseases which is not evident, we have to investigate for that. One is genetic test. So, genetic test should be done not for all the cases of FGR. So, to be done when there is gestational is less than 32 weeks, that means early onset FGR. Early onset FGR mostly related to genetic abnormality or infection, or if there is any structural fetal structural anomaly or any ultrasound soft markers. Soft markers are the certain anatomical changes in the fetus which is not itself a anomaly, but that increases the risk of anomalies or aneuploidies. So, if soft markers are there or fetus growth anomalies are there, then also that is a indication for genetic testing. Or if there is FGR with polyhydramnios, usually with fetal growth restriction, Leica amount decreases. If Leica amount increases with FGR, then there may be chances that there is some aneuploidy is present. So, in that case also you have to do the genetic testing. So, genetic testing can be done in various way. So, non-invasive method is by doing NIPT, that is called non-invasive prenatal testing. You have to take the blood from the maternal from the mother and test for the cell-free DNA. Other tests are more confirmatory, those are amniocentesis or chorionic villus sampling. So, you have to take the amniotic fluid from the maternal abdomen, and that is subjected to the chromosomal microarray to see for any abnormalities there or not. So, what are the indications for testing for infection? So, one is if there is any sonographic marker of infection, if there is an echogenicity or calcification in the fetal liver or fetal brain, while sonography if you are getting any calcification or echogenicity inside this organ, or if there is hydrops, fetus is swollen and fluid is deposited, in that case you may think of infection, then you have to go for torch test. If there is any maternal history or physical examination suggesting the infection, suppose the woman is chronically exposed to certain pests like cat exposure, that can increases the chance of toxoplasma infection, or if patient had history of fever with rashes or without rashes, in that case there can be chances of other virus infection, that is can be tested by torch. So, if clinical history is there, clinical science is there, or sonography finding is there, then only we usually go for infection testing in FGR, otherwise not necessary. So, what is the difference, what is the speciality of early onset FGR? As I already told, less than 32 early, more than 32 late. So, early onset FGR is more dangerous than the late onset FGR, because here the perinatal mortality or morbidity increases, it increases in 30% more than the late onset FGR. It is more severe and more likely it is associated with placental dysfunction and maternal hypertension. Whenever there is development of the pregnancy associated hypertension early in the early weeks, 20 weeks, 24 weeks, 25 weeks, in that case simultaneously the FGR also starts. Greater rate of umbilical artery Doppler abnormality. So, as I have already told, Doppler abnormality is there means it is a severe FGR. So, abnormality will be more seen in case of early FGR, Doppler abnormality will be more in early FGR. So, regarding the management, so certain general management will be there. Serial evaluation we have to do for the fetal growth every 3 weeks. So, why 3 weeks? Why not 1 week, 1 or 2 weeks, why not 4 weeks? Because it has been seen that if you measure the fetal parameters, there will be certain inter-observation variability, inter-observation and inter-observer variability. That means, if I measure it today and if I measure it tomorrow, there will be certain difference will be there anyhow. So, that is error in the measurement, certain error will be there, and that error will be surpassed, or that error will be obviated whenever it is more than 3 weeks. So, if it is more than 3 weeks, any such error will be more evident, and you can differentiate between the inter-observer measurement variation with that of the actual variation. That is why it is said that you have to see the growth after 3 weeks only, not before that. And if FGR is suspected, then at least weekly evaluation should be done for the amniotic fluid and umbilical Doppler, because amniotic fluid amount may change rapidly within days. Doppler change can occur within hours also. That is why it has to be seen at least weekly. Many times we see every 3 days also, to detect any abnormality developing rapidly. And non-stress test or biophysical profile should also be done, and that usually we are doing it weekly or bi-weekly. So, that is the machine is there by which we have to connect to the maternal abdomen, through which we record the fetal heart rate. So, that is called as non-stress test or biophysical profile. Then detailed anatomical survey should be done to detect any anomaly is present or not in the fetus. Amniocentesis can also be done to detect for the genetic cause or the infection. So, these are the general management. Specifically, what are the algorithm? I will show you. So, our main motto is to judge the optimum time of delivery. Here in FGR, it is very difficult to give some medication. It's no such medication exists which will increase the growth of the fetus, because fetus is growth retarded due to some reason, and that reason if can be corrected, then it's okay. If not corrected, then no other medication is there which will increase the fetal growth. So, the risk is that always there may be chances of IUD in the as the fetus grows. So, as the fetus grows, the metabolic demand also increases, but the supply is gradually decreases, relatively decreases. So, there can be more chances of IUD in the later part of the gestational age. So, we have to deliver the fetus before it reaches 40 weeks, and that at what gestational you have to deliver, that you have to judge it. So, in one side there will be difficult extrauterine existence in a preterm baby. If you wait till a long time, then there may be chances of IUD. So, you have to weigh between the two, whether you will risk the IUD or we will risk the preterm delivery. So, the algorithm is, if you are suspecting the fetal growth restriction, detailed obstetric sonography should be done to measure the parameters, whether it is correctly taken or not. Obstetric Doppler or velocimetry should be done to know whether it is severe FGR or a mild FGR. Then genetic testing may be done, as I have already told, the indications are there for genetic testing, indication for infections are there. And maternal, you have to see for whether polyhydramnios is present or oligohydramnios is present. Usually oligohydramnios is seen, polyhydramnios may indicate genetic abnormality. Then maternal serum and amniotic fluid testing for torch infections. So, these are the things you have to do when you suspect any fetal growth abnormalities. Then once you diagnose the FGR, then you have to go for the monitoring. This is for the monitoring. How will you monitor? Serial fetal growth assessment every 3 weekly. Then umbilical artery Doppler velocity measurement every weekly or bi-weekly. Amniotic fluid assessment again same weekly or bi-weekly, and fetal surveillance. So, you have to keep the mother and fetus in surveillance, so that before any serious event occurs, you have to deliver the baby. So, suppose by this monitoring, if you are getting abnormality in the Doppler. So, if normal Doppler is there, what you will do? In abnormal Doppler, what you will do? So, this is the normal Doppler. This waveform is normal Doppler. Normal Doppler means there is continuous flow of blood in the fetal vessels. In fetal vessel, during systole also blood flows, during diastole also blood flows. This is the systole. Here the blood flow is peak. Here in diastole blood flow, although at the lower position, still some blood flow occurs. So, continuous blood flow should be there in fetal vessels, and this is normal Doppler. So, in normal Doppler, you have to do the same surveillance, 3 weekly fetal growth, Doppler you have to do weekly, and ultimately when you are getting effective fetal weight 3rd to 9th percentile, then delivery at 38 to 39 weeks. And the fetal growth is less than 3 centile, in that case you have to deliver at 37 weeks. So, the more the fetal growth restriction with normal Doppler, earlier you have to deliver. You got it? This is the flow chart for normal umbilical artery Doppler. So, in umbilical Doppler, we have to measure many parameters. One is pulsatility index, one is resistance index, one is SD ratio, systolic by diastolic ratio. These are the certain formula are embedded in the ultrasound machine. Once you put the probe over and you have to see the waveform, automatically the SD ratio, PI and RI is calculated, but out of which the PI, the pulsatility index, is more preferred for the monitoring of the FGR fetus. So, here you can see, compared to the last diagram, this is the diastolic flow here, no diastolic flow is there. So, this is called as absent diastolic flow. So, absent diastolic flow indicates more severe FGR. So, here consider for hospitalization, corticosteroid should be given for fetal lung maturity, NST should be done 1 to 2 times per day, and umbilical artery Doppler velocimetry 2 to 3 times per day, and fetal growth assessment every 3 weeks. So, more you have to be more vigilant and more actively you have to search for the abnormality. Then in that case delivery at 33 to 34 weeks. So, absent diastolic flow do not go beyond 34 weeks, you have to deliver it. So, umbilical artery Doppler becomes abnormal whenever 30% of the placental villus vasculature is damaged. So, once 30% vascular damage occurs due to any cause, maybe due to thrombi, maybe due to any embolization, maybe due to the placental abruption, whatever may be the cause. So, there may be abnormality in the uterine artery Doppler. When it is 60% to 70% damage, it will be absent or reversed. The flow will be absent or reversed. So, here you can see Doppler, this is the systolic flow and diastolic flow has gone down. So, this is reversed and diastolic flow. So, whenever there is reversal of the flow, it is more serious than the absent flow. So, here again the same thing, hospitalization, corticosteroid, NST we have to do 1 to 2 times per day, umbilical artery Doppler 2 to 3 times per week, almost same as that of the absent Doppler, absent diastolic flow, but here delivery 2 weeks earlier, that means 30 weeks to 32 weeks. So, deliver the baby little earlier than the previous one. So, whenever you are getting effective fetal weight less than 3 percentile and Doppler abnormalities, then you have to act accordingly, act immediately, otherwise fetus may die inside the uterus. So, abnormal Doppler means whenever there is no absent flow or reverse flow, there can also be abnormality. Suppose you can see here, this much is the diastolic flow. Suppose the diastolic flow decreases up to here, it is coming like this and going like this. So, diastolic flow decreases. So, in that case, how will you know how much decreased? That can be known by the pulsatility index. So, abnormal Doppler defined as the pulsatility index more than 95th percentile. So, if there is 95th percentile Doppler is there, umbilical artery Doppler, then there is decreased flow to the fetus. So, not only the umbilical artery Doppler, medial cerebral artery Doppler also indicates fetal compromise. So, usually with after umbilical artery Doppler abnormality, the medial cerebral artery Doppler abnormality starts, but in many cases it can start without umbilical artery abnormality. So, that occurs in 20% of cases. In 20% only MCA abnormality may be existing. So, what happens whenever there is decreased blood flow to the fetus, fetus will try to conserve its blood supply or divert its blood supply to the vital organs. So, vital organs means brain and kidney. So, brain and heart. So, if brain and heart has to be supplied with blood, so that fetus will survive. So, in that case what happens, although the blood supply to the kidney and skin decreases and intestine decreases, blood supply to the heart and brain will continue. So, in that case blood flow in the medial cerebral artery will increase with mild FGR or mild compromise. So, here you can see this is a normal medial cerebral artery Doppler. Here systolic flow is very high and diastolic flow is less. So, this is normal. In MCA the resistance is more, that is why systolic velocity is more and diastolic flow is very less. So, but what happens whenever there is compromise, the systolic flow will remain same or decrease little and diastolic flow will increase. This is a compensatory mechanism, that is called as brain sparing effect. So, in brain sparing effect diastolic flow will increases. And in late onset FGR, reduction in CPR, cerebroplacental ratio. So, this ratio of the MCA with that of the umbilical artery is divided, and that is CPR, and if CPR is altered, then there may be fetal compromise. So, not only umbilical artery, MCA and ductus venosus also indicates fetal compromise in FGR. So, this is ductus venosus Doppler. So, here you can see ductus venosus is there, and the normal pattern of ductus venosus Doppler is M pattern. Here you can see this is M pattern of waveform. So, whenever there is compromise to the fetus is sufficiently severe, in that case there will be absence of the A wave. Here you can see this is the diastolic flow A wave, and this is absent here and reverse here. So, here is not there and it is going back. So, reverse A wave. So, reverse A wave means it is absent blood flow, diastolic blood flow in the ductus venosus. So, usually the absent or reversed A wave is occurs after the reverse flow in the umbilical artery. First the umbilical artery abnormality appears, then the MCA appears, then the ductus venosus. So, by the time ductus venosus abnormality starts, fetus is sufficiently compromised. So, do not wait till the abnormality to develop in term pregnancy. So, what is the management? This is the how will you monitor in the antepartum period. So, how will you monitor and what are the precautions, what are the events will be there in the intrapartum management. So, if placental insufficiency is present, there must be some placental insufficiency in case of late FGR, then that may be aggravated by labor. So, why it is so? Can anyone tell? Roll number 5. Roll number 5 is there. Why placental if placental insufficiency is present, that will be aggravated by labor. Rule 7 is there. Those are not responding, they will be marked absent. Rule 18, 5, 7, 18 are absent. You are 18. Okay. So, can you tell why there will be that will be aggravated by labor? I could not hear. Okay, sit down. So, during labor there will be constriction of the blood supply to the fetus. The vasculature inside the uterine wall that will be constricted due to the contraction of the uterus. So, the less blood supply will occur during the labor. Labor means during contraction. So, already fetal blood supply is compromised, it will be more compromised with each contraction. So, that is why it is aggravated by labor. Then oligohydramnios usually seen in case of FGR. So, cord compression chances are more because there will be less cushioning effect. Then neonatal hypoxia and MSL incidence is high. MSL means, can anyone tell MSL? It is meconium stent liquor. So, whenever fetal compromise occurs, fetus may pass stool inside the uterus, and this stool will stain the liquor, and that is MSL, that is called as MSL. So, MSL indicates fetal compromise or fetal hypoxia. Newborn, in newborn what happens, there can be chances of hypoglycemia, polycythemia and hyperviscosity syndrome. Long term complications can also be there in FGR babies, like delayed impaired neurodevelopmental outcome, poor motor, cognitive, language, attention and behavioral outcome. So, many abnormalities can also be seen in FGR cases in later part of the life. So, one is Becker's hypothesis. Becker's hypothesis means adult mortality and morbidity are related to the fetal and infant health. So, if fetus is FGR or abnormal, it may manifest in the adult life. So, in that case hypertension, atherosclerosis, diabetes and metabolic derangement can also be seen in the later part of the life. That is called as Becker's hypothesis. So, how to prevent it? Prevention of the FGR. So, it can be prevented preconceptionally if the mother is having some maternal diseases like hypertension, renal disease, that has to be optimized. Smoking cessation should be done, and nutritional deficiency, if anything is there, that has to be corrected before pregnancy only. During pregnancy, no such preventive methods are there. Aspirin can be given, but it will prevent only FGR related to preeclampsia, not any other FGR. So, that is why during pregnancy we are not able to do anything significantly, but preconceptionally you can check for it. So, what is the take home message? So, most important thing is to how to identify the FGR. If you identify it correctly, then you may deliver the baby early, or you may monitor it properly, so that you can prevent the mishap. 40% of late pregnancy IUD are due to FGR. So, many times it lands in FGR, IUD. So, it has to be detected early. Doctor's Benes's evaluation is particularly important in early onset FGR, and in late onset FGR, cerebroplacental ratio is more important. So, Doctor's Benes's early onset and late FGR CPR. Okay. Thank you. Done cutting.